Hello and welcome back to a brand new episode of Clotcast, the podcast all about disorders of the blood. I'm Dr. Yazan, and today I'll be talking to you about the treatment of venous thromboembolism, or venous blood clots. This will be the last episode in a series on venous thrombosis, and if you want to learn more about the symptoms, risk factors, or prevention of venous blood clots, please watch the previous episodes in this Clotcast series. Now, to be clear, this series is about the common or general type of large vessel blood clots, such as deep vein thrombosis or pulmonary embolism. This is in contrast to other rare or unique syndromes that can cause blood clots, such as those that cause microscopic blood vessel thrombosis, or immune-mediated blood clots, or catastrophic blood clots. There's a lot of them that are rare and unique in their pathophysiology, and there's a lot to discuss about those syndromes in future episodes, hopefully. I've mentioned in previous episodes that the complications of venous blood clots can be quite serious or life-threatening, and sometimes they're not. It's quite variable. Some blood clots may not even have symptoms, may not cause issues, and others can cause severe or lifelong complications, and sometimes even death. So it's very important to recognize and diagnose blood clots as soon as possible when we suspect them, and to initiate treatment as early as possible as well. So today I'll be talking about how do we treat blood clots and what are the goals of treatment. So I like to think of it as short-term or immediate goals as well as long-term goals. The immediate goals, when the blood clot is first recognized or diagnosed or suspected, are to make sure that we prevent its complications, as well as stabilizing the clot, preventing it from getting bigger, propagating, or breaking off and traveling somewhere. So first and foremost, we evaluate their condition on presentation. Are they in a stable condition? Are their vital signs okay? Are they breathing okay? Are they in need for urgent transfer to the ICU? Are they in need of any urgent life-saving interventions? Are their lungs and hearts okay? Heart. Unless if it's an octopus with 3 hearts. So first things first, ABCs, and then we need to make sure the blood clot is stabilized, that it's not going to get bigger and dislodge and travel somewhere else and cause further problems. How do we do that? If the patient is in a stable condition, not critical, not life-threatening, the first line of treatment is the use of anticoagulants, commonly known as blood thinners. These are medications that suppress or inhibit your body's ability to form new clots. So by doing so, we make sure that the existing clot isn't getting bigger, that new clots aren't forming or propagating and then traveling and dislodging elsewhere to cause more problems, and they also help stabilize the existing clot. What they don't do is they don't actually dissolve the clot themselves. They're not clot busters. There are medications that can do that, but their risk of bleeding is far too high, and typically these are reserved for conditions that are life-threatening or critical. In patients who are in a critical situation or life-threatening condition, different interventions may need to be done first. These include the use of catheter-directed thrombolysis, so a type of medication, a clot-busting medication that can be directly infused into the affected blood vessel, and this can be particularly useful for very massive blood clots with a high burden or those that are causing immediate complications. Other interventions include thrombectomy, or the removal of the blood clot by an interventionist, or the use of systemic thrombolysis. So these are clot-busting medications that can cause significant bleeding risk, but may be necessary in particular conditions. Now, going back to the traditional blood thinners or anticoagulants that we use in the treatment of venous thrombosis, they come in different kinds and methods of administration. So there's subcutaneous, there's intravenous, there is oral, of course. And the choice of the blood thinner depends on various factors, including what is the current context. Is the patient in the hospital in a complicated type of course that may typically require intravenous interventions first? Or is this maybe an uncomplicated blood clot that can be immediately treated with a oral type of blood thinner? For the uncomplicated type of blood clot, so these are the ones that typically can go home the same day, don't have any significant complications or need for hospitalization, our first choice are the oral anticoagulants. And in particular, the first line are the factor Xa inhibitors. This includes apixaban and rivaroxaban, also known as Eliquis and Xarelto. There are other oral anticoagulants, such as dabigatran, as well as you may have heard of warfarin because it's existed for a much longer time. However, it has fallen out of fashion because the newer ones are just much more convenient and generally better. That's for many different reasons. Warfarin has a very narrow therapeutic window. It has to be monitored regularly, while the newer ones don't need to. You need to watch your diet because different things can interact with its mechanism of vitamin K inhibition, bleeding risk, clotting risk if you fall out of that narrow window, and so on. So it's not a preferred treatment, but it is a preferred treatment in very specific types of scenarios. More on that later, but these include mechanical valves, antiphospholipid syndrome, and so on. I definitely want to plan a future episode on antiphospholipid syndrome, which is a rare disorder that can cause very serious and recurrent blood clots that can be life-threatening and sometimes catastrophic, and it's very under-recognized. Most people have not heard of it. Anyways, more on that later. Let's go back to the general venous thrombosis. So, next thing I want to talk about is the long-term goals of treatment. The long-term goals of treatment are to prevent this from happening again. We don't want this blood clot to come back, but at the same time, we want to make sure that by whatever means we achieve that, which is the blood thinner, that we don't cause a different problem or the opposite problem, which is a bleeding side effect. So we have to make sure that whatever treatment we're giving is not causing more harm than benefit. How do we determine that? Whenever I evaluate a patient with a blood clot, the context of that blood clot matters a lot clinically. Is there something that caused it, or did it just happen out of the blue? And if something caused it, is this a major or a minor risk factor? So was this a very subtle provocation that led to a blood clot? Or was there a very obvious explanation, such as a big surgery or a prolonged hospitalization? And I talk about the risk factors more in a previous episode. And then if there was a risk factor, was this a transient risk factor, or was this a chronic or persistent risk factor? Meaning that was this a one-time thing? They had a bad infection, that infection is gone. They had a big surgery, and that was it. Or was this a chronic or persistent risk factor, such as comorbidities, having cancer, having multiple risk factors for blood clots, such as immobility, obesity, hypertension, diabetes, and so on. And all of that matters in helping us determine the risk of recurrence of a blood clot. If there was a transient major risk factor, so there was a big event that happened and was a one-time thing, they had a major surgery or injury or so on, then we don't expect that blood clot to come back. There was a cause, it happened, and it's gone. However, if there was no risk factor, meaning that it just happened out of the blue, then these patients are much more likely to have recurrent blood clots in the future. And that risk is about 5 to 10% annually, and it's cumulative with time. These patients typically require indefinite or long-term anticoagulation because the risk of a recurrent blood clot is higher than the risk of a bleeding side effect from giving a blood-thinning medication. However, if this was a major transient risk factor, aka a provoked venous thrombosis, then we usually just treat it for a finite period of time, typically 3 months, sometimes 6 months or longer, depending on the situation. And in these cases, we don't expect it to come back once we've stopped the blood thinner. There's always a gray zone. There's always these in-betweens where, for example, there was a risk factor, but it was a very minor one. And that kind of makes us think of it more similarly to having no risk factor. Or, for example, having a chronic risk factor, someone who may be immobilized, have other comorbidities, and so on. So there's always a lot of nuance, and that's why a proper and thorough evaluation of the patient's risk factors, history, presentation, and so on is quite important in determining the best approach on whether this patient would benefit more from being on a blood thinner or not being on one long term. And I mentioned that because a lot of the time, it's not clear-cut. When it is, it's great. The treatment is obvious, not a whole lot of dilemma. But most of the time, or maybe at least these are the ones that end up in my clinic, these are the ones that are tricky. It's a gray zone. There isn't a clear answer. And so it requires a lot of nuance. And that's important that these types of decisions are made by a specialist, by a board-certified hematologist, when it's uncertain what the best course of action is. And as a patient, you may want to also seek the expertise of a specialist if you're hearing different things or something doesn't feel right in the treatment approach that's been recommended to you. And lastly, the other part of long-term goals is to also address any long-term complications of the blood clot and long-term symptoms. For example, a big DVT can cause post-phlebitic or post-thrombotic syndrome that can cause chronic swelling or chronic pain in the affected leg. Also, big blood clots in the lungs can cause lung problems such as CTEPH or chronic thromboembolic pulmonary hypertension, heart problems, as well as liver problems. So if someone has a big clot in the portal vein, that can sometimes cause liver failure or chronic complications. So there are chronic things that need to be addressed if they were to happen. And I'll talk about these in future episodes, hopefully. All right, so to wrap up, here's a summary of today's episode. The treatment of venous thrombosis includes the immediate goals, which means the prevention of complications of the blood clot, as well as preventing it from getting bigger, propagating, or embolizing somewhere. And that includes recognition of the most important things: any critical condition, vitals, hemodynamic instability, and so on that may require life-saving measures, as well as the initiation of anticoagulants or blood thinners that would help stabilize the clot and prevent it from breaking or enlarging and traveling elsewhere. This is our usual approach, and in specific scenarios, the use of clot busters is indicated. This is a much less likely scenario and is reserved for life-threatening or critical conditions where their benefit outweighs their risk of bleeding. In addition to that, there's the long-term goals, which is preventing the recurrence of a blood clot. If we think that a blood clot is at a high risk of recurrence because of a persistent risk factor or even the lack of a risk factor, meaning it was an unprovoked blood clot, then those patients would benefit from remaining on the blood thinner for a long term. If, however, this was a provoked blood clot by a major transient risk factor and not a minor one or a persistent chronic one, then the predicted risk of recurrence of the blood clot is low, and these patients would only benefit from a finite period of anticoagulation, after which the blood thinner could be stopped with a low risk of recurrence, typically less than 5%, in contrast to 5 to 10% in those who've had an unprovoked blood clot. And lastly, the long-term side effects and complications should also be addressed, including post-phlebitic syndrome or any other complications, including lung disease or heart disease that may have been caused by the blood clot. All right, well, that's it, folks, for today's episode and for the series on venous thrombosis in support of World Thrombosis Day. For more information, please visit worldthrombosisday.org, or is it .com? I think it's .org. I'll write it in the caption for more information on blood clots. And please let me know in the comment section below if you have any specific topics or questions you'd like me to cover in future episodes, and I'd love to do that. Thank you all for listening, and I hope you found this useful.